Our next speaker is Kathryn Hunt. And Kathryn is an intern pharmacist at Flinders Medical Centre in South Australia. She's graduated with a Bachelor of Pharmacy from the University of South Australia in 2017 and has recently completed a month-long rotation through the Intensive and Critical Care Unit at Flinders Medical Centre. Welcome, Kathryn.
Thank you. So as a pharmacist, we have vested interests in medication management, and particularly we know that a downfall of this management of medications is transitions of care. So this research was an opportunity for us to kind of get a bit of a snapshot of a tricky transfer of care and the medication management associated. So vancomycin is what we were looking at. It's an intravenous glycopeptide antibiotic that we use in a variety of gram-positive infections, including MRSA or endocarditis. It's only effective in gram-positive infections because of its interaction with bacterial cell walls. Ideally, we give it as an IV infusion over at least an hour. The duration's quite important because of the risk of infusion reactions, and too rapid administration can result in these infusion reactions that can cause delays in therapy. In most circumstances, we give it as a 60-minute infusion once, twice, or 3 times a day. And as it can cause some serious adverse effects, including kidney toxicity and ototoxicity, it's really important that we monitor the levels to kind of maintain this balance between toxicity and therapeutic. So therapeutic drug monitoring is our main mechanism of monitoring drug levels in our patients. We analyse a drug concentration sample at a set point in a dosing interval. In the ICU at Flinders, we've got a continuous infusion protocol, and we generally use this for the benefits that it has on these therapeutic concentrations. Intermittent infusions give us these peak and trough concentrations, where at the end of the dosing interval, you have the potential for the drug concentration to be too low to effectively be killing bacteria. These 24-hour infusions that we give continuously, though, give us this kind of steady line that maintains a concentration above this inhibitory concentration that we need. So prior to looking into this transfer process, we did a literature review to find any evidence as far as effective transfer of drugs that require therapeutic drug monitoring and how these transfers can be facilitated. There was limited information available, so it kind of made things a bit unique. We did find some information as far as stress ulcer prophylaxis therapy, which is common in intensive care, where we initiate medications such as pantoprazole to reduce the risk of these stress ulcers. Unfortunately, we have seen that these medications are often continued post-ICU and post-hospital discharge, where once the patients leave ICU, there's often no longer an indication for them to be on these medications at all. So this kind of shows us that these transfers of care can be maybe better managed. Our initial intention for the study was to review medication management when the patients are transferred out of the intensive care unit. And we considered this as an opportunity to assess how closely we're following a protocol and identify where we could potentially improve our practice, both as a multidisciplinary team in the ICU and once the patient's transferred in collaboration with the medical wards themselves. And a point in the transfer process that we can monitor quite closely is the therapeutic concentrations of vancomycin once they leave intensive care. And because it's so important that they maintain these therapeutic concentrations from both the safety and an efficacy perspective, we use this kind of as a method of analysing how well this was going. So the investigation was undertaken at Flinders Medical Centre. We are a tertiary intensive care unit. We have 32 adult beds, and we're a major South Australian teaching hospital. We considered all eligible patients in a 17th month period between 2017 and 2018, and it was information was collected from the inpatients who transferred from intensive care to the wards, continuing their vancomycin therapy. The use of the infusion protocols, the continuous infusion protocol, is restricted to patients in the ICU, so it's required that the patients are transferred to intermittent dosing when they're discharged. Initially, we set out with the intention of collecting prospective data, but we're kind of aware that with prospective data we're unlikely to achieve sufficient patient numbers to make conclusions. So we did also use some past patient records for some retrospective data. And the information that we collected included the patient's ICU dosing and their ward dosing of vancomycin, in addition to their levels and all changes of infusion rates or doses in ICU and on the wards. And undertaking this study, we considered all patients administered vancomycin during their ICU stay, and then assessed the patients who continued their vancomycin post-ICU. And there were a total of 31 patients who fit this specific criteria. Now, of our patients we studied, we had a median age of 61, which was a 62% of a male population. The patients spent a median of 3 days in ICU and also 3 days on vancomycin infusions. On transfer to the ward, our patients had a median renal function of about 66 mils per minute, so this is indicating some degree of renal impairment. Across our 31 patients, none required renal replacement therapy during their ICU stay. Prior to the ward, our patients had a median vancomycin concentration of 19.1, which with a continuous infusion is a bit lower than we would expect. And prior to the ward transfer, our patients were on a median infusion rate of 8.8 mils per hour, which equates to about 1,753 milligrams across the 24-hour period. And ideally, the 24-hour ward dose should be quite similar to this. So in consultation with our senior ICU clinicians and considering our protocol that we have at the hospital, we considered an ideal transfer to relate to 4 specific points, relating to the cessation of the infusion, the initiation of the intermittent dosing, and the therapeutic drug monitoring once the patient leaves ICU. In our 31 patients, we found that the first intermittent dose was given immediately following the infusion stopping in 19% of our patients. And we also found that in the patients who didn't have their dose given immediately, the longest time to dose was 22 hours and 45 minutes, which is a bit longer than we'd expect. And converting our doses from continuous to intermittent dosing was done appropriately in 52% of our patients. In those that this wasn't done appropriately, it was converted to high in 9 of our patients and to low in 6 of our patients. And ideally, once a patient reaches the ward, a drug level is taken within 2 doses and a maximum of 48 hours. This was appropriate in 81% of our patients, but those who didn't have their level taken within a suitable time frame, the longest time to dose was 7 days. Time to level was 7 days. Now, when the first ward level is taken, we aim for a level between 15 to 20 milligrams per litre. This was reached in 55% of our patients, but in those who didn't have an appropriate therapeutic level, we noticed a range between 5.4 and 28.4, which is both extremely low and extremely high for patients on intermittent dosing. For 13% of our patients, though, who had these levels taken, they weren't a true trough level, so it is hard for us to interpret that information appropriately. On analysis of all of these points, we found that the 4 points of an appropriate therapeutic transfer wasn't achieved in any of them, but individually the points were achieved. So considering what we think to be an ideal transfer for patients out of the ICU, we aim for a patient's serum vancomycin level to sit within this box. So this serum concentration, this represents a serum concentration between 15 to 20 milligrams per litre that is taken within 16 to 48 hours or 2 intermittent doses post-ICU. The data shows that about 6 of 31 patients are within this space. So there's obviously room that we can improve. Unfortunately, though, we were limited by a small study size with a 32-bed unit as a single site. Additionally, vancomycin's not our go-to for most infections. We use it in quite specific cases, and often our ward-ready patients aren't receiving vancomycin anymore. Additionally, we had many factors that influenced collecting our data. The staffing on medical wards is different. The change in supply of medication to wards can influence or result in dose delays potentially. Additionally, with our data, we didn't collect more detailed information on the clinical picture of each patient. So whether some of these doses were converted higher or lower may have been appropriate looking at that individual patient in that individual circumstance. So that suggests that maybe in these situations, deviation from these protocol is appropriate. But from the results, we're aiming to improve how we manage these patients and manage these transfers of care. So we're doing this by reviewing protocol, identifying areas that we could potentially improve this, and we're also increasing implementing some education to pharmacists, doctors and the nursing staff on how we can improve these practices. Thank you.
Thanks, Kathryn. Any questions? Yeah, I have a question, Kathryn. You know, despite the issues of compliance, was there any associated patient harm with vancomycin not being given in the method that it should have been given when patients went to the ward?
It's hard to know because we didn't collect further information once the patients actually got to the ward. We only looked at that snapshot of them on that transfer process. Mm-hmm. So we really didn't collect anything past that. So it's hard to know.
Mm-hmm. And where are you going to go next with this data?
That's something that we've yet to discuss, but potentially doing this as kind of a bigger picture, as maybe looking at the longer term outcomes of patients who have these infusions and whether the patients who require these infusions have poorer or better outcomes longer term post ICU.
Any other questions? Thank you very much, Kathryn.
Thank you.